You. Um, Hi, everyone. I'm very honored to be invited to this respected forum. I gave a talk to your group 6 months ago when I just started at Natera. I'm currently the medical director, but in my background, I'm a nephrologist. I was trained in Israel and moved to the US in 2016 to work with Friedel Hildenbrand. He's one of the I was pretty lucky because he's one of the leading scientists in the space of gene discovery in CKD. So we analyzed cohorts with specific phenotypes, pediatric cohorts, with, for example, nephrotic syndrome or Kakut, or ciliopathies and so forth. And with exome sequencing, we try to find common genetic variants in these groups. By that, we could find novel genes and work them up functionally and report them. I'm also still working part-time at the Brigham as a clinician at the genetic clinic, and I will share a couple of cases from my experience with you. Um, and for today, 1 second. Yeah, okay. Today, I wanted kind of to review with you the latest genetic testing recommendations coming from guidelines like KDIGO and KF. Who should we test? What are the circumstances? How we integrate the genetic testing in our practice, kind of practically. And very importantly, by sharing those cases, I want to explore with you the clinical utility. Because kind of that's the question that I think most people are interested to hear. Okay, what is the utility? Say we do test our patients. What is the benefit? And so I hope to show you some of the benefits that we can gain from testing our patients. So around the world, scientists like Freedom have, for like 2, 3 decades, been discovering genes the way I told you. But and they discovered more than 600 genes, and until 2019, we didn't really know what is the incidence, prevalence, what is the burden of these monogenic disorders in our real world CKD population. And that started to change with a pivotal study by Groupman and colleague from Columbia University. They published their findings from an exome sequencing analysis of more than 3,000 patients with CKD or end-stage kidney disease, published in the New England Journal of Medicine. And what they showed, kind of as a first proof of concept study, a diagnostic yield of about 10%. So 10% of those, being in dialysis and having all kinds of clinical diagnosis like diabetes or hypertension actually had monogenic etiologies to their CKD. In 2020, the first broad renal genetic panel was launched, making it possible for the first time for clinicians to use all that knowledge accumulated for the benefit of their patients. And 2 years later, Tony Blair's and colleagues publish their experience with the first 1,000 gene panel, renal gene panels. And what they showed in this real world setting is that the diagnostic yield was 20%. So 1 in 5 patients with CKD was found to have genetic test driving his disease using broad kidney disease panel. This and few other studies led the KDIGO to sit for a controversy conference, kind of focusing on genetics, the role of genetics in CKD. And, to summarize their report that was published in KI in 2023 in 2 words, and I use their words, is think genetics. So that was the first societal endorsement of broad applicability of the genetics in CKD evaluation and workup. And they actually summarize it saying, we have to get used to the fact that genetics play a more significant role than we ever thought. And so in our management, diagnosis and management of our patient, we should think about this option. The RenaCare study was published the same year, so in 2023, and that was the first comprehensive prospective data coming from kind of real-world evidence of from more than 30 centers, CKD centers around the US, enrolling more than 1,600 patients, showing again a diagnostic utility of about 20%. But interestingly, 50% of those who had positive genetic test results actually had a new or reclassified diagnosis thanks to this test. 90% of the providers reported that the positive test results helped them manage the patients. And in fact, 1 in 3 patients had an actual change in treatment based on the genetic test results. So it was the first time to show that genetic testing not only improves the diagnosis and the diagnostic yield, of CKD, but also drives better management of our patients. This is a meta-analysis published by the Coniton Group from Canada. They collected more than 60 studies that enrolled collectively more than 10,000 adults with CKD, and they showed a diagnostic yield of 40% on average. That varied based on the population selected, obviously, and it was as high as 62% in the cystic kidney disease patient group. Not surprisingly, family history or presence of extra kidney features did increase the diagnostic yield, but somewhat surprisingly, older age at time of testing was not associated with a decrease in this diagnostic yield. Another important observation in this meta-analysis is that the reclassification rate that they established, and again, this is more than 10,000 adults with CKD, was 17%. What do they mean by reclassification? I'm not going through all of these examples, but on the left of this graph, you can see the pre-test clinical diagnosis. And on the right, after the test, after the genetic test was conducted. If we take, for example, diabetic kidney disease as a clinical diagnosis, 45 patients, if we try to follow the diabetic to the right, we see that only 12 patients remained with this clinical diagnosis. The rest received a new diagnosis, which was genetic in origin. Vascular kidney disease. We often label our patients, as you all know, when we don't have a better explanation for their CKD as vascular, because they have all kinds of other cardiovascular risk factors. And you see that 55 patients labeled like this with a clinical diagnosis of vascular kidney disease, out of these, only 8 remained with this diagnosis after the test. So that's just to show that the reclassification was significant and actually helped us to change the diagnosis for those patients or diagnose them from scratch. So all this data really drew attention by our leading organizations, and KDIGO in their CKD guidelines or management of CKD guidelines dedicated a kind of section for renal genetics, and they mentioned genetics all through the guideline. When should we use it and so forth, and I'll talk about this more. That was followed with the NKF genetic recommendations published in their consensus statement, focusing solely on genetics in CKD. And the same year, in 2024, beautiful review by Asaf Vivante in New England Journal, Genetics of CKD. Earlier this year, the first KDIGO ADPKD management guidelines, again, with a dedicated section on genetics in the PKD population. Who should we test? What are the benefits and so forth? We'll discuss this in more detail. And quite recently, KDIGO published also guidelines on management of nephrotic syndrome in children, again, with specific recommendation on when should we test genetically. Not shown here. Very recently, 2-3 weeks ago, KDIGO again, April 1, controversy statement. I'll touch shortly on this report as well. So what are the key takeaways? We'll start with the KDIGO, and the first key takeaway, first, in general, they say, we should put emphasis on establishing a CKD cause wherever possible. That sounds trivial, and we all think we know what are the etiologies of the CKD, driving CKD in our patients. But if we really kind of honestly think about it, we often, as I said before, label, vascular, diabetic, without a hypertensive, without a real proof. And so, although sounds trivial, KDIGO highlights, hey, we should really put all efforts to establish the true cause of our patient's CKD. So, what they suggest that genetic testing be an integral part alongside all these other routine tests that we all use, right? Urine analysis, serologic test, ultrasound, kidney biopsy. Genetic testing should go along this, all this, so kind of added to the toolkit. They do remind us, KDIGO, that we should obtain a careful family history for possible genetic causes. Now, that also sounds trivial, I'll be honest. When I was trained in nephrology, that wasn't highlighted by any of my mentors. So I think that's important for all of us kind of to read this and remind ourselves when we see our patients to obtain careful family history, because that increases significantly the likelihood of a genetic disorder if the history is positive. When should we fit it in? Should we use it as a last resort when we exhaust all other means of, diagnosis the etiology? So guidelines like KDIGO tells us no. Consider it, as I said before, as part of your toolkit, initial toolkit. And there are many reasons for that. In some cases, it can obviate the need for a kidney biopsy. I will show examples. In other cases, it can guide us and tell us, hey, this patient with FSGS wouldn't benefit from immunosuppression, so you better avoid it. And it can be negative and reassuring, or it can end the diagnostic odyssey quite fast. So when we think about serologic tests for patient with proteinuria, we should also think genetic. That is kind of the bottom line. Who are the patients that we should think genetic for, right? So this is from the NKF, recommended clinical indications for genetic testing. And I highlighted in yellow those that kind of I consider at least the low-hanging fruits, meaning if these are positive in our patient when we take history, we have high likelihood to find a genetic cause, a genetic etiology for their CKD. So these are positive family history, multi-organ syndrome, early onset kidney disorder. The cutoff kind of somewhat arbitrary is put at 50, recurrent electrolyte or mineral abnormalities, including kidney stones. Well, these are kind of obvious, if you like. The green ones are more broad, a little more vague, less granular, but I think are super important because if we take these yellow ones as inclusion, as exclusion criteria, meaning if the family history is negative, we are not going to test, we sure are going to miss many patients. And again, I will show you a couple of examples. The green ones, though, they being broad, but they force us to think about all possible scenarios. For example, number 12, all kidney-related abnormalities where genetic etiology is suspected. Well, this is not very specific, right? But you have kind of the small print beneath that covers, I believe, most of nephrology. Cystic, glomerular, tubular interstitial, and so forth. So in other words, NKF tells us we should consider genetic testing for the majority of our patients. We can use it, as you can see in number 13, to clarify an atypical phenotype, for example, cystic kidney disease, we'll discuss it more later, or to guide therapeutics in nephrotic syndrome. And interestingly, number 14, they say, we should discuss this with the patient and offer genetic testing if requested by the patient. So, for whatever reason, and we don't need to, question them, why do they want to know? But patients want to know. That's the bottom line. Most of the patients just want to know what is the etiology, what is driving their disease. They want to be able to plan their family. They want to be able to match the right kidney donor. Or they may just feel it's important for them. So we should offer it. That's per NKF. And for me, number 15 here is, I don't want to say the most important, everything is important, but that's kind of what mainly drives my decision in clinic if I should test or not. Because I ask myself a simple question. Do I really, truly, honestly know what is driving my patient's CKD or whatever disorder? kidney disorder. So CKD of unknown etiology or end-stage kidney disease of unknown etiology, as I said before, we tend to think that we know if what drove our patients to end-stage kidney disease. But if we really look at dialysis centers, and we see that 70% are labeled as hypertensive or diabetic kidney disease, we probably miss a lot there by just giving this clinical label, as I showed you before with the reclassification graph. So I ask myself this simple question: do I know really what is driving the disease? If the answer to myself is no, I tend to offer a genetic test. Which modality should we use? So NKF suggests that we use large multi-disease kidney panel unless we know from a family member what is the gene variant, and then we can test specifically, kind of targeted testing. Otherwise, uh, large panel. How come? Because we know that a lot of our CKD, many of our CKD patients have non-specific symptoms. So they present late, CKD4, we don't know what happened. Often we don't biopsy them at that late stage. And so it's very challenging to target or to tailor a very targeted panel, with few genes, trying to kind of hit the right gene that is involved. On the other hand, if we use too broad of a panel like whole exome sequencing or whole genome sequencing, we may just have too much information and variants of uncertain significance and regions that are non-coding that we just don't know what to do with. So NKF believe that the comprehensive kidney panel strikes the right balance between the two. The next key takeaway from this is what is the benefit? So the guidelines, NKF, the KDIGO, all of them say there's a lot of benefit in genetic testing in nephrology, and highlighted this one benefit that genetic testing can direct personalized treatment if available. And the reason I highlighted it because I often hear that question from colleagues. Why should we test? We can't really give, we don't have a pill for each of these different genetic disorders. Well, okay, so it's nice to know, but we cannot do anything about it, so we are not going to test. And I refer them to this box one from NKF of potential benefits. And I tell them, this is one bullet point, important one. I'm not saying it's not, but it's only one bullet point, which is relevant for few diseases like hypoxaluria or Fabry disease or cystinuria, but there are 14, 15 other bullet points that are also benefits for the patients, and they're super important. It can facilitate or confirm a diagnosis and the diagnostic odyssey and shorten the diagnostic journey, establishing prognosis, reassuring if it's negative, avoid, as I said before, biopsy or immunosuppression, which wouldn't be effective, family planning, donor planning, and so forth. So there are many benefits other than directed therapy. Now, as of the directed therapy, currently there are about 30 or more trials, ongoing trials. And there's a lot of excitement now, and really, I think the field is shifting, and the number of pharma companies interested in developing medications for these rare genetic variants is increasing exponentially. And so I'll mention a couple later. I want to move to cases, and through cases kind of to learn more about the benefit and touch on a couple of new guidelines. Just to mention that all these cases were somewhat modified for HIPAA reasons. Um, and also, I wanted to say that if you want to interrupt me, I'm more than, you're welcome to. If that kind of becomes a discussion and not just a seminar, I'm happy to answer questions. And if anyone has question before I move on for the first part, I'm also happy to pause for a second and take your questions. Okay. If not, so let's start with the first case. And also to mention, a few of these cases are actual All of them are real-world cases, and a few of them are actually from my clinic. The first is a patient diagnosed with ADPKD, so autosomal dominant polycystic kidney disease, 30-year-old male with kidney cyst identified incidentally at age of 28 during imaging for back strain. He does have hypertension, but normal kidney function, and importantly, negative family history. Now, you may say, okay, PKD is a clinical diagnosis. We count cysts and we diagnose it. And you won't be wrong saying that. But still, there is a rationale for genetic testing. Because of the family, the young age, the unknown etiology, and the negative family history, there's a rationale, which is also endorsed by the KDIGO guidelines, to test genetically. In this case, we found a PKD1 heterozygous pathogenic mutation. As you can see, for the fellows or people who are not aware of this kind of nomenclature. So this is the variant here. You see the C change, kind of the change in the position on the cDNA. And this is a deletion of two nucleotides leading to a frame shift. That's the FS with a star, meaning there's a truncation of the mRNA. This 50% of polycystin will not be formed because of this truncating mutation. This is a common um, finding in ADPKD, so it's not surprising to see a truncating mutation in PKD1. In fact, PKD1 variants are responsible for, together with PKD2, for about 90% of the ADPKD. Today, we know that there are other minor genes responsible for the rest. But you may ask, how come his parents are healthy if it's autosomal dominant? Well, this is also not uncommon, and about 10% of our PKD patients actually have what we call de novo mutation, meaning the mutation that was developed in the zygote, and so it wasn't inherited. Uh, Once it's there, there is a chance for this patient to pass it down the next generation. The chance is 50%, but he did not get it from any of his parents. So by the genetic test, we were able to prognosticate, to discuss the management. He'll probably need tolvaptan because this is kind of leading to a severe phenotype in most cases, the truncating variants and so forth. So, and we had a diagnosis. So from an incidental finding, we had a concrete, defined diagnosis for his disease. The second case is a patient with atypical cystic disease. So 40-year-old female with few kidney cysts, two on the left, one on the right. Her kidney volume size is completely normal and the function is normal. So I guess many of you attending, hearing this say, yeah, we have many patients with few cysts here and there. Why should we test them? These are most likely acquired. I mean, it's not rare to find a couple of cysts in a 40-year-old female. Well, this is right, this is correct, but again, what guides me at least is if something kind of doesn't smell right. Why does she have these few cysts and negative family history in this case, and the kidney volume is and the kidney function is normal. We know that these acquired cysts are more likely to develop in CKD. So I wanted to know what is driving her kidney cysts. And we found a heterozygous pathogenic mutation in IFT140. This is one of those minor genes that I mentioned before. We know that, in general, they are associated with a more mild phenotype than the PKD1, truncating definitely variants. There is a chance for kidney failure, but it's much smaller. So again, we establish a diagnosis. So, we reassure the patients also that this diagnosis is usually associated with a milder course. And we also advise her, let your family know, so this question will not arise again as a surprise. And first degree adult relatives, family relatives should be screened. Again, ADPKD, 45-year-old male with the clinical diagnosis of autosomal dominant PKD, bilateral cysts, and also positive family history. Multiple people in the family in a dominant kind of manner have CKD and kidney cysts. This patient has a declining eGFR, so developing CKD, but his kidney cysts don't grow. They are relatively stable in size. So there's some discrepancy from the classic PKD scenario that we are used to, that the size of the kidney drives the kind of the reduction in eGFR. Also, the patient was recently diagnosed with type 2 diabetes. So because of this discrepancy between the GFR and what we call Mayo imaging classification that kind of takes into consideration the volume of the kidney, and as aligned by the KDIGO guideline, we decided to test this patient, and we found a heterozygous pathogenic mutation in a gene called HNF1 beta. This is a gene known, when mutated, to cause a syndrome that could be variable. One of the presentations of these symptoms could be renal cysts and diabetes, RCAD. That's exactly what this patient has. So he was recently found with diabetes, he has kidney cysts. So his family doesn't have ADPKD. They have HNF1 beta related disorder. Now, interestingly, because of the variable expression of HNF1 beta, it can also result in different phenotypes. And I had a patient who presented with ARCAD, with renal cysts and diabetes, with negative family history. And when we kind of dig deeper, we realized that her dad had the same mutation, but agenesis of one kidney. So he was born with one kidney, and that was the manifestation of the HNF1 beta variant. And but his creatinine was fine, and it was just overlooked. So I'm trying to highlight here that even if the family history is negative, don't give up on the thinking on the genetic test. It is relevant in many cases. This is a CKD of unknown etiology in a female who presented with stage 4, CKD stage 4, earlier attributed to hypertension and non-steroidal anti-inflammatory drug use. She does have a history of gout, siblings with few renal cysts, father who is a kidney transplant, and another family member with a history of end-stage kidney disease. So she does have few cysts as well, but CKD4, and this was attributed to her CKD stage. We decided to test her, and we found a pathogenic mutation in UMOD. So this is a well-known cause of autosomal dominant tubulointerstitial kidney disease. And the reason I'm bringing up this case as an example is that if you look at the clinical characteristics of UMOD-associated ADTKD on the right, you will see that these are quite non-specific. And, if you think about it, I'm sure you can find kind of remember many patients coming into your clinic with these clinical characteristics. Hyperuricemia, many of our patients with advanced CKD develop high uric acid levels. Gout, not that specific, right? Occasional renal cyst, the same, especially with patients with advanced CKD. Now look at the range of development of end-stage kidney disease. This range is well known to be, there's well-known phenomena of interfamilial variability for UMOD ADTKD. And that's, again, just to say, if the family history is negative, do not exclude the genetic cause, because family members can present differently and the diagnosis can be just overlooked. So the patient doesn't know of any positive family history. So when you take history, they will tell you, no, it's negative. Again, uh, don't give up on the genetic test, or at least the consideration of the genetic test. And the leading, the guiding, what should guide your decision is the simple question that I keep repeating: do we really know what is the etiology? And for me, hypertension and NSAIDs use is not good enough. Okay, so I presented few cases with cysts. I'll go briefly over the PKD guidelines that were published recently. And in this table, you see the indication who should be offered genetic testing. And this is kind of specific to patients with cysts, right? So the cases that I described to you with the negative family history, discrepancy between EGFR and MIC and so forth. But at the end of it, KDIGO says, hey, consider or offer, discuss genetic testing with all people. if they want to know, we should offer this to them. And I think, it's not only curiosity. They want to know because they are curious people. KDIGO provides this table as well with possible value of early screening, genetic screening of PKD patients. And we discussed most of the benefits like Resolve Diagnostic Odyssey, initiate screening for extrarenal manifestations, for example, and so forth, reassurance if it's negative, family planning, and so forth. But for me, one of the important benefits is to enable enrollment in clinical trials. As I mentioned in the beginning, specifically for PKD, there are, I think, 3, 4 clinical trials. And now they enroll not only based on the gene involved, but even based on the variant. So if we do not test our patients, they miss an opportunity to be enrolled in a clinical trial. And later on, when these medications, hopefully soon, are out there, we cannot match the medication to our patients simply because we don't know what is driving their disease. Um, I will skip this one. I think okay. I wanted to kind of to give another example of PKD, but not for the clinical scenario, but you will see in a second why. So this is a male from my clinic with a classic presentation of ADPKD, positive family history, MIC class 1C, hypertension, PKD. I send a genetic test and it's negative. And that is very common in PKD. And so you may wonder, how come? I mean, it's all classic ADPKD with positive family history. So the next thing that we look in a typical report is at the other results that we get. So the first one is positive, negative. In this case, no pathogenic variant was found in this panel. Carrier results, I see there's a pathogenic heterozygous variant in ITGB4. Well, and the inheritance, the report is telling me that could be autosomal dominant. Well, I'm not familiar with this gene, so I look at the little script beneath, and I see that a single heterozygous pathogenic variant in this gene is associated with epidermolysis bullosa of hands and feet. Well, my patient didn't have any of these. He had kidney cysts, so I can just skip it because the phenotype doesn't match. And then I go to the next level in the report, which is the variants of uncertain significance. And I just uh, these are hidden for HIPAA reasons, but you can see that the list is long of variants of uncertain significance. Those that the classification, we don't have enough data to classify it either as pathogenic or benign, so it kind of remains in this gray zone. And one of these variants of uncertain significance is PKD1. And that kind of fits the phenotype, right? And it also fits the zygosity and inheritance pattern. So I said, well, that's very suspicious. I wrote to a genetic counselor who came back to me with questions from the company who sequenced this sample, and I replied with more clinical information. And after a week, I received a response saying that this variant was upgraded, reclassified to likely pathogenic. So when you have this situation of VUS and when you see, okay, this is a suspicious VUS, you contact the company, and this communication is critical because the company is blind to the clinical manifestations, but what they do have is a large genomic database. And so this communication between you, the people who actually take care of the patient, and the genetic counselor is critical to reclassify those variants. Now, in PKD1, I also wanted to mention, as I said, it's a common finding because most of the PKD1 variants are so-called private variants, meaning they are shared by only few families, and therefore often there's not enough evidence to classify them as pathogenic. So keep it in mind. This is a female with microhematuria and albuminuria, and I also wanted to show kind of a case where the genetic result is unclear and what do we do next. And she has a remote biopsy that I didn't have access for, but she said it was either IgA nephropathy or Alport, I'm not sure. She does have an extensive family history. Brother, end-stage kidney disease, kidney transplant with hearing impairment, second brother with microscopic hematuria, and the sister with microscopic hematuria and proteinuria. And I said to myself, well, that must be col4a5. I mean, the brother, the male, is more severely affected. The female also have something. And I tested her and it was negative. But then I looked at the variants of uncertain significance and found this col4a5, and I said, okay, Eureka. And I again talked to the company, and the next step really, and that's what they also told me, and is to do a segregation analysis, meaning, hey, let's get all the clinical data from family members and their genetic reports and try to put it kind of on a family tree and understand what's happening. So here's my patient with the VUS in col4a5. And in circles are the females, in squares are the males. This is a mother with microscopic hematuria. So I started with the youngest sister with hematuria and proteinuria and found that she also carries the col4a5. And I said, well, I think I nailed it. But then, to my surprise, she also had a likely pathogenic variant in col4a3. So I said, okay, that's confusing. So I went to the other siblings and I see that the healthy brother, who is older than her, also has the same col4a3 likely pathogenic. In other words, the most likely driver of disease in this case is the col4a5, although it's a VUS only. This is not yet fully solved case. I promise to get back to you when I know more, but the next and the critical information will come from the transplanted brother, and we're going to see which variant does he carry to kind of try to resolve what is the true driver of disease in this family. And this is critical to know because my patient has 3 kids, 2 males, 1 female. That can affect how we screen them, how we manage them, and what we expect or predict from their disease. Next case, FSGS of unknown etiology, male patient with hematuria on routine visit, and then proteinuria that developed, leading to a kidney biopsy that showed FSGS. He is now CKD stage 4 in his 40s. So to clarify the etiology of proteinuria and FSGS, we did a genetic testing and found col4a5 a mutation, so leading classic Alport X-linked Alport syndrome, where males have only one copy of X chromosome. Therefore, it's called hemizygous, and therefore we also expect a more severe clinical outcome. Now, Alport syndrome is very often misdiagnosed. This is from the Groupman paper from New England that I mentioned initially from 2019, showing that 62% of patients eventually found to have variants in col4a3, 4, or 5 were actually misdiagnosed or not diagnosed at all. So 62%, that's huge, right? Which clinical diagnosis did they have? All kind of other stuff like hypertension, unknown etiology, and so forth. So, when I studied medicine and when I was trained in nephrology, no one taught me that FSGS, when I see FSGS on a biopsy, I should think Alport. The contrary, if you see FSGS, it's something else. That's what I've been told. Look for the basket weave, look for the thin membrane, stuff like that. But in fact, guidelines written by Judy Savage from Australia, one of the leading experts in the world on Alport syndrome, suggest that genetic testing is more sensitive and specific than kidney biopsy and is the recommended as the gold standard modality to diagnose those patients with suspected Alport. Who these are? Those with persistent hematuria, persistent proteinuria, steroid-resistant nephrotic syndrome, or biopsy-proven FSGS. So for me, I think that's a paradigm shift, and so we shouldn't kind of just assume that we know a diagnosis when we have FSGS, because FSGS really can be the end result of so many different etiologies. Now we have a tool that can really nail the molecular diagnosis in a large number of our patients, and that can guide therapy because this patient will not receive steroids, immunosuppression, and we know how to manage extrarenal manifestations, screen family members, and so forth. From my clinic, another patient with FSGS found incidentally to have proteinuria, and the kidney biopsy showed FSGS, and we tested her. But also, we learned that she has a brother who presented with very similarly 4 years ago with FSGS, and now he's a kidney transplant. And guess who is the donor? Their oldest sister. Was he tested genetically when he developed the end stage, I'm sorry, the FSGS and received immunosuppression? The answer is no. And so did his sister who donated the kidney. So he received the transplant without knowing the actual diagnosis. For our patient, we tested and found TRPC6, mutation in TRPC6, which is a known cause of FSGS, actually. So I bring this case just to highlight the importance. Again, this is, I think, the fourth example of negative family history. When the brother presented, no one else in the family was known to have kidney disease. The parents were completely healthy. And so that was missed. So when the physician saw the brother initially, they didn't think genetics because of negative family history. That could have resulted in a catastrophe because a donor with this TRPC6 could have developed the disease later on. Same for the recipient. Luckily, we tested her retrospectively and she is negative. Proteinuria of unknown etiology. I know I'm at time, so I'll go quickly through this. But this is a case of APOL1. I just wanted kind of to bring this to attention because it's a very hot topic also with recent guidelines. So this patient carries a homozygous or dual risk variant in APOL1. We know that that drives kidney risk dramatically. So up to 30-fold increased risk, for example, for FSGS, or 15% chance to develop end-stage kidney disease for patients with dual risk variants. And these are quite common, especially in the African American population, with 13% of them carrying the dual risk allele and 30% carrying one risk allele. This is just one snapshot from the recent controversy paper from KDIGO. I think it's last month. Basically, you can look at the box. I'm not going through all the details, but the idea is that we don't need to screen anyone from the right ancestry, I would say. That could be just discriminating, and obviously it's a sensitive issue. We shouldn't just use it as a screening tool for everybody. But if the individual has a established kidney disease, CKD, proteinuria, FSGS definitely, or is a prospective living kidney donor, or a relative with an APOL1 high-risk genotype, when these are together with a clinical disease, we should test them and with genetic testing. Last two cases, very briefly. Hypertension, also very common, I believe, in all of our clinics. 60-year-old male, African American, with hypertension and hyperkalemia and mild CKD. His family history is also positive for both hypertension and hyperkalemia. And, I was just assumed or predicted that I'm going to find again APOL1 variant in his renal genetic panel test. Well, I did, but only one risk allele, which currently we don't know that is driving risk for CKD. But what was positive is a likely pathogenic variant in KLHL3, which is actually the cause of this long name syndrome, which in short is also called Gordon syndrome. So as you know, driving hypertension and hyperkalemia. And so we do have a targeted therapy. It's called the thiazide diuretic because it actually acts on the channel that is dysfunctional in this disorder. And this patient is now normokalemic and normotensive, and his family knows now how to deal with their hypertension and hyperkalemia just thanks to thiazide. And the last, it's a case I always love to share because it shows, it taught me that I should think also outside of the box of these typical scenarios of FSGS, APOL1, Alport, PKD, all these kind of common scenarios. Here is a female, 52 years old, that had normal kidney function, normal blood pressure, negative family history, and the reason she was referred to us was hyperphosphatemia. That's it. She does have a history of rheumatoid arthritis, which was seronegative, and she was treated with multiple lines of therapies like Enbrel, Humira, methotrexate, steroids. Nothing really helped. She also had dry eyes with angioid streaks that were associated to her rheumatoid arthritis. And she also was found to have calcification of her breast, and that kind of initiated a malignancy screening. Well, we were interested to learn about the etiology of hyperphosphatemia. So we sent a renal genetic test, and what we found it was a homozygous, likely pathogenic variant in GALAN-T3, an autosomal recessive cause for hyperphosphatemic familial tumoral calcinosis. Well, that's a long name. In short, GALAN-T3 is in the pathway of FGF23, which is phosphaturic, as you know. And so when this doesn't work, FGF23 doesn't work, and people develop hyperphosphatemia. So that was interesting. We kind of nailed the diagnosis or the etiology of her hyperphosphatemia. But what was striking for me is that when I read about this long name syndrome, I realized that all of her symptoms that were previously attributed to rheumatoid arthritis are actually typical for this syndrome. So, but in simple words, she does not have rheumatoid arthritis. And we talked with her rheumatologist, and we just took her off all the medications that, one, didn't really help, two, were toxic, three, were not appropriate for this particular syndrome. So we just focus our efforts on balancing her phosphor levels. So this is from the KDIGO. These are the benefits, just illustrative way. Quickly, there are targeted therapies, but also non-targeted, management decisions are important. Avoid immunosuppression, biopsy, assess risk of recurrence in a kidney transplant, like is it atypical HUS or monogenic FSGS? We can assess what is the risk. Should we screen for extrarenal manifestations like diabetes in HNF1 beta or intracranial aneurysms in PKD and so forth? And we want to help our patients to plan appropriately their family and kidney donation considerations. So with this, I summarize, and again, I borrow the words from KDIGO. It's a short summary. Think genetic. And thank you for your attention. I think we have 5 more minutes for questions, and I'm happy to take them.
Yes, and thank you, Dr. Schneider. So if people in the chat want to raise their hand, I will unmute you and then you can say your question. Jerome, I have allowed you to talk, so you should be able to turn your mic on now.
I don't have a question. I don't know if I raised my hand by accident.
I guess it was overwhelming. If you guys have, questions that pop up down the road, clinical question, at any point, I'm very passionate about kidney genetics. I'm always happy to discuss, try to help brainstorm with you guys. Before the test, after the test, when you get kind of results that you're not sure what to do with, you're always welcome to discuss with our genetic counselors, with me. And I'm happy to share my contact later with Marisa.
Thank you, Marisa. I do have a comment and a question, if I could.
Yes, please.
This is Dan Badley. Thank you for a very nice and informative presentation. I was interested in one of your first slides where you showed that many patients with type 2 diabetes, I don't know, out of 50 plus, many had the unexpected mutations. And that brings up for discussion the issue of non-diabetic kidney disease in a diabetic patient. If you go by biopsies, we did one of the first studies with the late Ed Lewis, probably was 15 years ago, and by biopsies, we found that about 20%, I think it was a very important finding, that 20% of patients with the diabetes suspected by the proteinuria and high ground findings didn't have it. I remember doing a biopsy in a patient that had membranous, just to show you. But that was 20%. And other studies more or less have replicated these findings. Now, are you telling us that if we go by genetics, we are going to find maybe 50%, and that poor metabolic control maybe just contributes to accelerate the disease, but the underlying cause is something else? I appreciate
Well,
it.
it's a great point. Thank you for this question. No, I'm not saying it's 50% simply because I don't know. This is a meta-analysis. Obviously, there's a selection bias. These patients, retrospective analysis just showing, they were tested for a reason in all these different studies. And so I believe that one of the key driver of the selection bias is when we see classic diabetes, really we are often not biopsying them, right? Most of our diabetic patients, I think, are not even biopsied because, if it's a long-standing A1C is, uncontrolled, there's retinopathy and so forth, we just say, okay, this is diabetic kidney disease most likely, or diabetic nephropathy, without even a proof. And in most cases of those classic cases, I guess we're right, and there's no genetic driver. I don't test these patients. Um, but all this gray zone, when something doesn't smell right, it's a short-standing diabetes. A1C is well controlled. There are no other complications. Is there another driver? That's the question. And what we see internally, and also few other studies like the Groupman and other studies who looked at this question, see positive genetic testing 10 to 20% of those labeled with diabetic kidney disease, 10 to 25% even in some studies. And again, it's hard to compare because of differences in selection bias, right? But again, that's what guides me. I'm saying if it's not a classic diabetic nephropathy, with what we learned kind of is the usual kind of evolution of diabetic nephropathy, I tend to test.
Thank you. Thank you.
Yes, I have a question.
Yes,
My name
please.
is R11, and I'm Professor Emeritus, long emeritus. I'm about to be 90, but nonetheless, I would like to know if you know the cost of the genetic testing, because many patients we have at Northwestern come to us without insurance or are on Medicaid, and it may be very difficult for them to assume the cost of such testing.
It's a great question, and obviously one of the first that we hear from our patients and providers. This is an unbranded talk. I can speak of the company that I work at. And also I can speak from my experience because, I joined Anatel only 6 months ago, as I mentioned, but I'm sending these tests for a few years now. Never, none of my patient was billed.
Oh,
So, or I should say, none of my patients paid out of pocket. It's not true that they were not billed, but those who were billed, the company took care of it. So it's a negotiation with the insurance company, and whatever is left is taken care of by the company. So the bottom line, very few patients, I'm saying less than 1%, got any bill. Those who did receive an kind of a payment bill, it was really, 12 bucks, 15 bucks, something like that. But the vast majority was taken care of in the back end. Your patients should know that they may receive a bill, but they can always contact the company and say, hey, we received this bill. Can you help us out? In close to 100% of cases, it's resolved. Um, Yeah, does it address your question?
Yes.
By the way, the cost kind of, let's put insurance aside, is not that high. It's not what it used to be. Kind of genetic testing used to cost thousands of dollars, right? Now it's not more expensive than, vitamin D level or PTH that we do every month or two. And we do it only once. So definitely in the long run, it's even way cheaper because we do it only once. It's not, it's few $100s, if we just don't consider any insurance or any issues like that.
Yeah. Thank you, Dr. Schneider, for for a wonderful talk. I'm sorry wasn't able to do your
Yeah.
presentation due to technical issues, but I don't think we have any more time for questions. But thank you again for gracing Renal Grand Rounds. Thanks, everyone.
Thank you for inviting me. Appreciate the attendance. Thank you.
Thank you.